the second patient is a 70-year-old male. He had an oropharyngeal cancer. And I think this is very important. Also, nowadays, we often see patients which have cancer in this area, and then somehow gastroscopy, upper GI endoscopy has been forgotten, and then the patient may develop metacronius cancer, or even they have synchronius esophageal cancer. So in this patient, gastroscopy has been performed, and there was a lesion 24 to 30 centimeters, 70% of the circumference. And you will notice now in the video, please, the video, in this case was very difficult to make a clear demarcation of the lesion. So even with the help of MBI, we see here some reddish epithelium, we see here regular epithelium, and now the question is how to proceed in this case.
Yes. So it's very difficult. So next slide. Yes, so factual diagnosis based on the second. So cancer, please raise your hand. Almost 50 and 50. 50-50. So in this case, very difficult. So white light endoscopy and a non-magnifying endoscopy, so it's very difficult make diagnosis, I think. What's your opinion?
Yeah, how can we proceed? We have now the new scope, we have IBCL, we have your classifications, but we are now completely confused in this case. Question is, do you still stain in such a patient?
Yeah, I think so. So previous case, number one case is very easy to identify the area of the cancer, but this case is very difficult. So lots of inflammatory changes we have. So it's very difficult to evaluate. So at that time, so most reliable procedure and a simple conventional procedure is, I think, Lugol staining.
Okay, thanks. Yes, with the Lugol, we have Lugol solution, and usually we use 2.5%. And do you still do this in Japan, or do you use less now?
So now we use a low concentration, like 1% or like that. So it would be much better. Otherwise, so patient feels very sick.
And what is also very important, many patients have pain after Lugol staining, and there is medication, natrium thiosulfate. You can get it in ampoules, and it's absolutely no problem. After you're finishing up with chromoendoscopy, you spray the natrium thiosulfate, and the Lugol solution is neutralized.
So, sorry, what do you spray?
Natrium.
Oh, the sodium thiosulfate.
Yeah, sodium sulfate.
Yeah.
Yes,
That's available as a particular brand name, or do you just your lab?
No, we contacted our pharmacy, and it is no problem. It's very cheap also, so no problem to get it.
And how much do you put down? How much?
10 cc.
That's it.
Yes, that's it. But so here we see this another lesion now with Lugol staining, but Haru, there are more optical phenomena we can use now with the new technology. Can you help us with this?
Yeah, so this is a kind of a NBI imaging of the pink color sign, so-called. So next, please. So like this. So after Lugol staining, when we switch to our NBI image, we can see a so-called pink color sign that is specific to squamous cell carcinoma. So pink color sign area is shining like this. So we call metallic silver sign. Okay.
So, sorry, did you use the word pink?
Yes, please come back. Previous slide. Okay.
So you mean the periphery is pink, or you? In English, we would just say metallic silver.
Yeah, metallic silver sign that looks silver. So, okay, in this case.
So maybe can we go a little bit ahead with the video. At the end, we have the staining in this patient.
Okay, please proceed the distal half of the video clip.
Doesn't work. We have to wait.
Doesn't work. Okay.
But I think here we notice again that it is really difficult to see neither the proximal nor the distal margin.
Yeah. So in this case, of course, the chronic inflammation and esophagitis, and then the cancer, it's coexist. Yeah. So it's very difficult to evaluate endoscopically anyway. So I think it's better to...
Yeah, but soon it will come.
Yeah. So now we approach close to the cancer tissue, and we can identify some abnormal vessels. But in this case, together with esophagitis, so very difficult to evaluate. And then finally, in this case also, like this iodine staining, we can identify the uncolored area. And then switch to NBI, we can see metallic silver sign on it.
Okay, so in this situation, I think we have several features for cancer with regard to the IPCL. Also, the staining was positive, and we used the new optical phenomenon using NBI. After Lugol staining, we had metallic silver sign, and now this is the resection of the lesion, and now we will ask our pathologist what he has found.
You see the resection macroscopically, and I will show you a slice from this point. On the next, on the next, you see this slide. On the edges, the epithelium is normal, but we will focus on these circles. On the next, you see the first circle. There is a squamous intraepithelial lesion high grade. On the next one, also squamous intraepithelial lesion high grade, and probably there is an invasion here. And the third one, it's gone. Okay, here. It's frankly invasive squamous carcinoma, M2.
And what about the margins? Because we always want to hear it is a R0 resection.
The lesion was like a mosaic over the whole excision, and some points of the margins were positive.
Okay. Do you have any questions to this for this case? I think to admit this patient also had his oropharyngeal cancer, and we performed this endoscopic resection before the radiation therapy in this patient, and I think it was at all a more palliative approach to this patient. I think.
Yes, and then so it's a very nice comment. So in this case, the histological evaluation, the margin was positive, but so this kind of lesion, so squamous cell carcinoma is always a dysplasia carcinoma sequence. So some part is a low-grade intraepithelial neoplasia, some part is a high-grade intraepithelial neoplasia, some part M1, M2, like that. So always continuous. So for example, in this case, if we want to make the margin negative, we have to resect all the esophageal mucosa. So if we do like that, so patient becomes a severe stricture. So in order to avoid that, so we found the major lesion, and then so.
But do you mean that some of the positive staining areas would still be dysplastic?
Yes. Yes.
Even if they stain with Lugol's, there could be dysplasia in such a lesion like this.
So when we discuss with a pathologist, so always we have a discussion, tough discussion, because so even when we this kind of lesion, so background mucosa is lots of dysplasia. So always lateral margin is at least low grade intraepithelial neoplasia. So it becomes positive. But so we can follow the patient if necessary. We can repeat the ESD if the cancer grows. So we can perform repeated ESD, and also if necessary, if we think it's necessary for the patient, we can also perform the ablation.